I'm delighted to be here to talk about impacts and risk associated with COVID-19 in the food supply. I will just sort of start with my obligatory conflicts of interest statement, which tells you what I have been involved in relative to potential conflict of interest, which really is not much. Before I launch into this, I really need to acknowledge Dr. Juan Leon, who is a faculty member at Emory University School of Public Health. He and I have together been working on putting the risk model together that I'm going to talk about at the end of this presentation. And particularly, Julia, his PhD student, has done most of the kind of boots on the ground work relative to this. So this is definitely a joint effort. But with that, I am going to start with the official statement about foodborne transmission. And Mike actually already gave this at the beginning of the symposium. I'll probably use the WHO statement, which is there is currently no evidence that people can catch COVID-19 from food or food packaging. And we stand by that statement, and that is very uniform throughout all of the agencies in the world. So this is not a foodborne pathogen. With that said, it has had significant impact on the food industry. And and that's been largely in the essential workforce. And so that's pretty much food workers. We'll talk a little bit more about that in a few slides. The first we saw of this in the US probably really was in the restaurant industry. But we also began seeing clusters of illness in meat processing facilities. And that actually expanded by probably the summer of 2020. We began seeing clusters of illness in other food manufacturing facilities, such as frozen fruit, such as seafood, even some prepared food manufacturing facilities. So clearly, COVID-19 was spreading amongst workers in these facilities. And there's a great study that was done in California that was able to kind of get a handle on how much this particular sector was impacted by the pandemic. And in the United States, we have this classification of essential workforce or essential workers. Those are kind of individuals that are necessary for health purposes, but also secondarily for keeping our world and economy going. And the food and agriculture sector is part of this essential workforce. And you can see here from this slide that they experienced excess mortality. They certainly experienced excess morbidity as well. And relative to some of the other members of the essential workforce, the food and ag sector was actually even more highly affected. Now, there are lots and lots and lots of things we can say about SARS-CoV-2, which make it kind of this unique pathogen. I am not going to go into a lot of detail on many of those, but I do want to make the point that, and it's a really important point, that there is a high level of virus shedding, both pre-symptomatically, so before people develop symptoms, and also in asymptomatic individuals. And that presents a huge issue because people are getting exposed to the virus from individuals that have no idea that they're infected. And that is an important, it's certainly not the only driver of the pandemic, but that's been an important driver of the pandemic. So let's talk a little bit about transmission of SARS-CoV-2. This is a largely a respiratory transmitted virus. There's some fascinating aerosol physics, engineering information that's come out of working with SARS-CoV-2. But basically what happens is certainly in the phase of disease where people are shedding a lot, most of the virus tends to be in the upper respiratory tract. And any activities that involve that, from as simple as breathing to talking, coughing, sneezing, yelling, etc., you produce this turbulent, this multi-phase turbulent gas cloud, okay, which you can see on the right-hand side. And in that cloud is a combination of air and droplets of various sizes, and those droplets are from very tiny to very large. And the virus tends to associate with those droplets. So if you become, if you are exposed to the turbulent gas cloud immediately, you can directly contract the virus from exposure to the cloud. And then there are also indirect transmission routes. And this slide is a great illustration of what those indirect, or kind of the cadre of exposure routes to SARS-CoV-2. So here is an infected individual. They, let's say, sneeze, and they produce droplets of all sorts. And if a susceptible person is in close contact with that gas cloud, they'll directly get infected by inhalation. The very large particles tend to settle quite rapidly onto surfaces. They just drop. And that is the source of virus contamination for what we call fomite contamination or surface contamination. And that results in infection if somebody contacts the surface and then manages to contact their nose or their mouth, or they basically self-inoculate. The smaller particles in that plume will stay in the air for long periods of time, and that could be hours, sometimes even days. And of course, they're going to get diluted out in the process, but the bottom line is that if you have spent a significant amount of time in an enclosed area where you have these small particles floating around with virus association, it's also possible to become inoculated or become infected in that manner. Certainly, straight person-to-person transmission is also is possible, although that is not what we've done in our model. We've addressed in our model. So what has the food industry done in order to address this issue? Well, they've pretty much done most of the controls that we have as a community at large put into place. They've instituted these controls extraordinarily quickly. Testing was really done mostly in instances of clusters. Some companies are also doing a little bit of screening testing. Vaccination approaches are just being just being started. And you can see on the right-hand side of this slide that there have been just a cadre of physical distancing controls that have been put into place. Now, I mentioned that these were put into place, and in an ideal world, we would have had data to inform what are the best mitigations to put into place, where, when, why, how. We didn't. We had to act very quickly, and so you can see here on the left-hand side of this slide, these are just some basic practices, but there's a ton of uncertainty about what really is the most effective mitigation strategy to address those. And so, of course, as a risk assessment person, it makes sense to inform this kind of decision making with quantitative microbial risk assessment. And I suspect almost everyone in the audience here is pretty familiar with risk assessment, so I don't really need to explain this slide. But suffice it to say is that we haven't really been able to use risk models because we didn't have sufficient data to make the initial decisions that we needed to make to manage COVID-19. Now we have more data, and we're starting to see risk models be produced. And I'm going to spend the rest of the presentation talking about a few of those. So this is actually a very early one, and I love this study. It's illustrative of the complexity of managing COVID-19, and it's also illustrative of a really simple but effective approach. So what these investigators were interested in was a cadre of potential controls, so low occupancy and high occupancy. They were also interested in ventilation, face coverings, or the effectiveness of face coverings. And they looked at, and also time period, contact time period. And they looked at how those all interface together to effectively express risk. And this is what's called a qualitative risk assessment. So there's high, medium, low risk. Red is high, yellow is medium, green is lower risk. And a great illustration of this would be for low occupancy conditions with good indoor ventilation. If people wear face coverings, they fall into the low risk category. But if they wear no face coverings, they fall into a moderate risk category, and that would be associated with a speaking action, for example. And you can make these comparisons across the board using this particular risk model. This is a very recent publication that was very interested in the relative importance of actions like breathing, speaking, singing, coughing, and sneezing. Remember, the size of the plume and how far it travels is all dependent upon the type of physical activity. And these particular investigators were interested in looking at the impact of ventilation or air exchange. And I'll just show you, for example, in the case of a sneeze event, they found that at an inoculum dose of about 10 to the 9th viruses, in a 2-hour period with no ventilation, the risk of infection was quite high, almost 100%. And when they were able to institute 6 air exchanges per hour, which is pretty moderate degree of air exchange, that risk falls down to about 50%. So relatively speaking, this shows how we were able to modify risk based on an intervention. So that leads me to the work that Juan and Julia and I and the Emory team have done. And we were interested specifically in a enclosed food manufacturing facility and how to manage COVID transmission within such a facility with respect to the essential workforce. We used as a model a frozen food facility with approximately 100 workers in the production line, and we asked 2 major questions: which transmission pathway was most important? Was it aerosols, in other words, the tiny droplets or tiny particles that last in the air for long periods of time, droplets, which are the larger droplets, or surfaces? And are the current worker protection strategies enough? And these were the worker protection strategies that we focused on in this risk modeling exercise. So to show you a very quick overview of the model, we began with an infected SARS-CoV-2 worker. We were looking at exposure of that worker, and then finally infection risk to that worker. We looked at aerosols, both large and small particle aerosols, as well as environmental or fomite sources of infection. And there were a number of factors that we investigated that were really important and for inclusion in the model. One is droplet size, because that impacts both distance traveled as well as how quickly something falls to another surface. We were very interested in distance between the infected worker and the susceptible worker. We modeled this within a 1 to 8 hour exposure that was indicative of a working shift. And as I said before, we looked at masking, we looked at air exchange rates, we looked at gloving and hand washing, and we looked at surface disinfection. Now, this slide just shows you sort of an overview of some, not all, of the parameters that were included in the model. A large number of the parameters we were able to get from published literature or literature, good literature that was in review. There were instances where we had to consult experts, particularly in the aerosolization area. And American Frozen Foods Institute was gracious and helped us get processing and facility dimensions, things like that, from their stakeholders. So I'm going to go back to our first risk modeling question, was which of these 3 transmission routes or pathways is the most important? And this is some of the early simulations that we did, and we were basically looking at total infectious SARS-CoV-2 on the y-axis as a function of droplet transmission, fomite transmission, or aerosol transmission, and distance. And overwhelmingly, we had the highest potential dose exposure at a 3-foot distance with droplets. And in point of fact, any of the other combinations gave exposure to a much lower dose of virus. So based on that, we were able to say that that droplet transmission appeared to be driving the outbreak in this particular venue, and that distance was a very, very important consideration. So with that, we went on and did some more simulations and looked at what the relative distance, what the relative difference in distance had based on, in this case, worker risk rather than number of viruses. And this is in association with coughing events. And if you note, at a 3-foot distance between worker and infected worker and susceptible individual, you can see here that risk, that risk increases with pretty substantially with time, but it is relatively low when you're at these longer or greater distances, and that is more indicative, of course, of aerosol exposure. And interestingly, risk hits almost unity. It's almost 100% if this distance of 3 foot over an 8-hour period of time is kept. We then looked at the impact of masking. We first investigated cloth masks versus surgical masks, and found them to be pretty at a distance of 3 foot between infected and susceptible individual. They provided risk reduction between 50 and 60%. If you double masked, you got about a 90% risk reduction, and if you used an N95, which is not used by this particular population, you could get it down to 99.9%. Okay, so that's at your 3-foot distance. As you increase distance, you get much better control, such that even masking with cloth or surgical reduces your risk to less than 1%. So masking is extraordinarily helpful. We also were interested in air exchanges per hour and its impact on risk with an 8-hour exposure. The industry standard is 2 to 6 air exchanges per hour in most of these facilities. We found, again, if at the 3-foot, distance air exchanges. As you increase the air exchange rate up to a high of potentially 8, you reduced risk in that short distance by about 50%. And if you were looking at further distances, you pretty much air exchange helped even pretty dramatically by certainly 4 to 6 air exchanges. And in point of fact, the contribution to risk reduction at the greater distance was not as overwhelming when as compared to the 3-foot distance. Okay, so once you've controlled or sought to control droplet transmission, then we wanted to also look at surface transmission, both associated with hand hygiene and disinfection. You can, a couple take-home messages here relative to risk. The contribution of hand hygiene and surfaces is much lower than the contribution of respiratory, maximum of a little bit over 20%. Although there is substantial reduction in that 20% risk by instituting hand washing and gloving policies, and also certain reduction in surface in the potential of surfaces to serve as a source of infection, particularly if you went down to every other hour of surface disinfection. So in point of fact, how do we actually do this? Well, in real life, we use multiple strategies. So the final simulation that we did looked at hand washing twice per shift plus sanitizing once per shift. And we combined that with distance, as well as with masking. And again, at the 3-foot distance, this kind of bundled strategy gave us about a 75 to 85% risk reduction. Double masking brought that up to 95%. And increasing distance, of course, brings the risk down to literally less than 1%. So bundled strategies work. So what's our summary here? Well, the focus needs to be, at least according to this particular risk modeling exercise, on droplet transmission at a distance of less than 3 feet. Once droplet transmission is addressed, surface transmission strategies to reduce surface transmission are effective. Combinations work. And based on our model, we really felt that the food industry practices do protect workers from SARS-CoV-2 infection. And I think the epidemiology is very clear that once these strategies were put in place, the clusters of diseases in these particular facilities fell pretty dramatically. So what are we going to do with this model going forward? Well, it's designed such that it can be used for a variety of other venues. We could use it in a restaurant setting. We can use it in other types of food plants with modification. Right now, there's a lot of interest in industry about the potential for transmission of SARS-CoV-2 in frozen food packaging. This is actually a big issue on the international scale. And so we are in the process of adapting the model to understand or to get a better feel of what exactly is the risk of transmission of this virus through frozen food packaging. And to just sort of wet your whistle for where we go in COVID management phase 2 as vaccination strategies are introduced in the population. We certainly want to look at the impact of vaccination and vaccination compliance on worker health in this particular workforce, and this model can definitely do that. We are also really interested in understanding and how, once vaccination becomes more widespread, what, if any, strategies can be relaxed, because this is what's being done now is really at great cost to the food industry as well as its workers. As we approach herd immunity, which is probably 85-ish%, how are we going to approach disease surveillance? You know, a little lower than herd immunity, we're going to still be seeing clusters, but we're going to have to be able to figure out how to detect those clusters, and that's going to be tricky. And that there may be a place for testing strategies relative to that. Certainly, we know very little about the variants and what their impact is going to be, and it's pretty clear that we're going to have to boost after initial vaccination, and so managing that is also a big black box. And with that, I will finish my presentation and be happy to take any questions.